All right, another Thursday. You know what that means. 5 studies on the docket, so let's knock them out of the park. This one's straightforward. What do your lifestyle factors, basically, what can you modify in your life that will influence low back pain? So they've tried to survey 5,000 Japanese adults ages 20 to 90. They got almost 2,200 to respond, and they asked them things like, do you have back pain or not? Is it chronic or not? And what other conditions do we need to be aware of so that we can kind of tie some together, basically looking at risk factors. So the categories were those with or without back pain, the severity of that back pain, and if it was chronic, and they wanted to see if body mass index, alcohol consumption, smoking, exercise, comorbidities, and their self-image regarding body shape had an influence, or they could tie it to different things with low back pain in a population, and they could. So when they actually put it through their little analysis, they found that low back pain was significantly associated with BMI, alcohol consumption, smoking, and dyslipidemia, or what is typically too high of triglycerides in your blood. You're not managing your endogenous or the fats, the natural fats in your blood. There's too many of them typically. And the severity of low back pain was tied with smoking, a lack of exercise, and again, dyslipidemia. Smoking was the only factor significantly associated with the chronicity, so chronic low back pain. This is what we already know to a certain degree. This is just, again, reinforcing that healthy lifestyles trend with reduced incidences of back pain. All right. These all interplay in so many different ways that I don't even want to start to get into on this video because I want to keep it a little bit shorter and manageable for both of our sakes. Now, double crush syndrome. This is the one that I can talk about a little bit, so I'm going to try and clip it and keep it short, basically explaining what it is. So double crush, what term? It's nebulous. Basically, double crush is where we see some sort of issue in the central nervous system or the very proximal peripheral nervous system. So think of the classic is a disc herniation, and that can either start to impact the cord within the actual canal itself, or it can kind of really, really piss off the nerve just as it starts to exit the outside of that vertebral body. And you'll get symptoms with it. A lot of people will complain about sciatica, like, oh yeah, no, my back hurts. Now I feel pain all the way down the back of my leg, down to my heel. Or maybe it's in your neck. Oh, I've got a neck disc herniation. So everything from here down is all sorts of tingling. The rub is that the nerve is a continuous tract from the brain through the canal of the actual vertebral body all the way out to your fingertips. So brain, column, and let's just take my arm here, all the way out to the fingertips. This is all connected. And the problem is that along that track, there can also develop a secondary nerve injury or impingement. So put another way, I could have an active disc herniation, a symptomatic disc herniation in my neck or low back. And I'm just going to stick with neck because I can actually show my hands here during the actual video. So I could have one that would explain my symptoms, but I could also have where that nerve lies in my arm also going through an injury process, an inflammatory or compressive process, depending on what's going on. And that is double crush. And the problem is you can't really parse out the two easily. And so very often people only think of what is obviously causing their problems and not considering the possibility of a secondary impingement site that could also cause some of the distal symptoms. This becomes relevant when we're considering intervention strategies of, is this a surgical candidate or not? Because when we have double crush, oftentimes it can exacerbate and make the actual disc herniation or whatever is causing the radiculopathy or radiating symptoms to be that much more severe, because now there's extra pain signals, let's call them, going through that tract. So it's like hypersensitized. So you look at this like, wow, that is bad. That is a disc herniation that I should send that to surgery right away, when it may not actually explain the distal symptoms. And then some people will get failed back surgery syndrome, where they go in and it may fix the proximal radiculopathy, like, yeah, I got this, whatever, maybe it's a discectomy with laminectomy, whatever the surgery is. And they're like, yeah, like right here, I don't have symptoms here, but my gosh, it is still whatever their symptoms were down here. So it's like a partial success, but now you're dealing with post-surgical complications because you had surgery. You're going to be opened up. They're going to do what they need to do, and they're going to get out. So you're going to go through that healing process from the surgery, rehab, etc. And so you may have a failed outcome when in fact it wasn't the, it could have been the right treatment, but it's the wrong time because there's a lot of factors to consider. Okay, let's put it that way. And depending on the severity in front of me, like I had one of these last week. Today's Thursday. No, actually, it was last week. And really severe symptoms. And she actually had an MRI, and it's like, oh yeah, I have on MRI a pinched nerve as it comes out of the L5 nerve root. And so you had some of those classic symptoms, but she was really complaining that it was intense, actually right along where this study highlights. So let me go through this and I'll finish up my patient's story with this. So this one took a look at the L5 nerve root and CPN, common peroneal nerve. So that's where it's kind of like, actually, let's not go with the exact spot. Think of the backside, the top backside of your shin. So if you go behind the knee, on the outside, as it goes down, in that area is where they're going to be talking about here. So I'm just going to slightly read through this because this is going to be the longest study, and I really think this kind of gets me going. This is the fun stuff. So the coexistence, keyword there, coexistence, or cannot be a double crush, of multiple compression sites on the same nerve can pose a challenge. Believe me, we know. Warranting a different treatment strategy. This is so far termed double crush syndrome, and it's a little nebulous in the actual research. Like some people agree, some people don't. I'm still in the camp because I've seen some of these that I will say, yep, it's double crush, and talk to my patients and educate them on this. They haven't really looked at it too much in the lower limb, and they wanted just to see in a clinical series, was this a possible diagnosis or diagnostic issue? And let's actually dive into that. Methods: all patients presenting in a 3-year span with an L5 nerve root compression and along their clinical course, concomitant compression of that nerve, that CPN, at the fib head were included. Information on clinical features. So what did this type of pain, like what did the patient experience essentially? The diagnostics and surgeries of these patients were obtained. And the outcome was assessed at the last outpatient follow-up appointment for each patient. In addition, they did a little lit review. So what were the results? 14 patients were included with a follow-up of almost 7 months. The majority of them had pain or motor deficits, so an inability to really use the limb, the lower limb in this case. 7 patients were referred for clinical and radiological L5 nerve root compression, but also were found to have that common peroneal nerve compression. The other 7 had persisting or recurrent symptoms after surgically or conservatively treating that L5 nerve root compression, which also then suggested that peroneal neuropathy. All patients had that CPN, common peroneal nerve decompression at the fib head, with successful results obtained in 93% of them. Pain at the lower leg improved in all patients, and the ability to pull your ankle towards yourself improved in almost 80% of them. What does that mean? Conclusion: concomitant L5 nerve root and common peroneal nerve entrapment appears to occur more frequently than expected. That lower nerve near that, so the CPN, common peroneal nerve, peroneal, you see it on there, neuropathy can present simultaneously with that L5 radiculopathy or after surgically or conservatively treating the compression at the L5 nerve root. Overlapping symptoms and variation in presentations make it difficult to diagnose and therefore is under-recognized. More awareness needs to be among treating physicians of the specific double crush syndrome to prevent any delay in treatment. In this case, a less invasive common peroneal nerve release at the fib head to avoid unnecessary additional spinal surgery. That is the key. Okay, there is a point that we could treat it, and that's what we tried to do with this patient last week, is we just introduced it. They were coming through town. They couldn't really stay to manage it conservatively. So our part in this was just diagnosis and letting them know that as they go through medical intervention for this, to be aware and bring their physicians up to speed on this syndrome so that should she pursue treatment and is recommended non-conservative care, that they go and look at where she feels the symptoms most intensely along her leg near the CPN. So if I can give the patient, even though I'd want a fair crack at it to actually manage it conservatively, sometimes you can't because it's not the right patient and not the right severity of the condition, or the patient doesn't have means. Like this one was a traveler through town. So there's no way that I have the ability or time to conservatively treat them. So should they actually warrant the traditional medical route, she now knows what to look for. The physicians can then find articles like this and go, wait a minute, maybe rather than jumping straight into the spinal surgery because we're going to get so laser focused on that MRI finding of the L5 nerve root impingement on her, that maybe they just do a focal nerve decompression where she feels most of her symptoms currently, and that may release so much of her symptomatology or resolve so much of her symptomatology that the rest of the symptoms she would have with just the L5 nerve compression are so much more manageable that she may be referred to an OTPT or have time for a DC conservative management and completely avoid spinal surgery. So that's why I love this stuff. This is why I peruse the literature. This is why I try and educate you guys. And really, this is a big one that I hope you take out of it. Like, this one is awesome. Like, I could almost just end the video, focus on this, and we're good. But the other three are kind of quick, so let's just knock them out. But if you want to stop the video, you don't. This would be the one to stop it. I'll just review this, review what I said. This is the thing. All right. So the last three. Screening of the thoracolumbar spine is almost completely absent in trials evaluating conservative management for SI joint pain. A systematic review of a ton of clinical trials. I don't really need to actually go through them. Like, there's not that much here. Basically, here's what they found, and this is all you need to know about it. Most of the trials reported minimal to no screening in that TL junction prior to developing an actual diagnosis that they have pain in the sacroiliac joint region, highlighting significant variability and scarcity. The role of screening that area prior to diagnosing pain is notably underrepresented in trials providing treatment recommendations for that condition, undermining the strength of conclusions derived from those studies. Put another way, you need to look at the whole spine because there's actually several conditions that can have referral patterns that go right over that area. And if you just jump right to the point or site of pain, it's basically like a crapshoot anyway. You're gambling. Oh, I have pain right there in the SIJ. All right, you have SIJ pain. I'm going to roll the dice. Maybe I'm right, maybe I'm wrong. Well, let's just screen the rest and figure out if there is any potential source referring from that area, because we catch a lot of that. Like, sometimes patients are like, hey, my pain's here. Yeah, I'm going to treat here. I'm not going to ignore that. Like, we're still going to take care of that, make you feel good. But the main thing I need to do is up here in that TL area. Well, what do you mean? Well, here, let me do these things. Like, whoa, yeah, I feel that. And that's going right down to the SIJ. It's like, that's why we're doing this. So more studies need to be done. And you need to have somebody that really looks at the whole picture, because he who treats the site of pain can often be lost, is a saying that is pretty common in my field. All right, last two. Screen time is associated with cardiometabolic and cardiovascular disease risk in childhood and adolescence. And it's essentially a linear, the more time, the increased risk. And that really should just be a kind of, well, yeah, because what happens? Screen time is associated with being sedentary. Excess sedentary activity is what truly causes a lot of these conditions. And a lot of that light disrupts our ability to start or initiate sleep. So you actually get sleep disturbances. So put another way, is a lifestyle factor that is correlated and almost causative of a sedentary lifestyle and is also causative of sleep disruption will cause major issues in your health long term. So this one was cardiometabolic and cardiovascular risk. So if we want to reduce that, give our kids and teens the best chance, we have to be disciplined about how much screen time we are actually allowing them to have, so that they pursue other active endeavors to reduce their risk of developing these conditions beyond their genetics. Because there is the genetic component. Like, some people, you can't dodge it no matter what. Or put another way, like, they're perfectly healthy, but then they actually get a blood panel and they have like familial hypercholesterolemia. Basically, it's just in their genes to have naturally high cholesterol. They're like, it's no fault of their own. I've seen extraordinarily healthy looking people have that condition. And so it is entirely genetic. But the entire other component is what a majority, in my opinion, YouTube, everybody, my opinion is that a majority of the chronic disease state we are seeing is environmental. Our choices, we are not doomed by our genetics. Okay. I hear people say that when it comes to their care. It's like, my entire family has bad backs. Okay. My entire family has osteoarthritis. Okay. You're not telling me that much about what your functional capacity is because you're not willing to test it because you're just blaming the genetics. There is a time and place. Believe me, when it comes to certain conditions, there is a time and place. You have a higher risk factor of so many diseases, blah, 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 because of who you're related to. But so much is in your control about what you develop, what diseases you're prone to based on your lifestyle. Active lifestyles are stereotypically healthy for a reason. Sedentary lifestyles are stereotypically chronic disease inducing for a reason. Okay? Preaching from the pulpit. This one's with kids, this one's with teens. Set them up for success. Don't eliminate the screen time per se. If you like, it's just the world we live in. We can't eliminate it because we don't want to make them social pariahs. But we must be disciplined in its approach because too much is a very bad thing. And this is what we're seeing right here in the evidence, okay? Moderation. Moderation is key. Now, soapbox over. And hopefully I didn't confuse people between the genetic and environmental. Like, there's a ton that you can influence. I see it in like gym goers, strongmen, powerlifters, bodybuilders. Some of them blame their genetics and only look at doing certain exercises because of genetics. Like, oh, I'm never going to get big because I have, small genes. You've just never really tried, and you're now using that as an excuse and a crutch that I've seen with patients use for various other conditions. It's like, okay, your genes tell you you're never going to get above 5'9". You can still do a load at 5'9". I mean, I just look at the comparison between, I watch Strongman. So Hafthor Bjornsson, giant of a man. I mean, he's approaching 7 feet. Eddie Hall is, I think, 6'3"-ish. He's like between 6'2" and 6'4". And then Brian Shaw is another one, gentleman, American-based out of Colorado. Dude's, I think, 6'10". Monster of a man. Eddie Hall, shorter, bad genetics for strongman in some events, because being short actually helps you in a lot of others. But for outright strength, they're like, well, the bigger men can tack on total more muscle. Eddie Hall, between all of them, was the first one to set a deadlift record. The first one. So his comparatively bad genes, and I don't want to get this flag like, Eddie, look, he's saying you have bad genes. It's like, no, I'm saying compared between the three, he's the shortest. So people would say, oh, he can't have as much total muscle mass on his body to do. He was the first one to break through the major deadlift record. Like, you have to respect the man because he didn't let that stop him from doing and breaking that record before all of them. Okay. I think I'm just going to confuse everybody at this point. Nature versus nurture, both play a role. It will dominate some aspects of your health. It won't be the only factor, and there's so much you can do that you shouldn't ignore or just let that be an excuse for a majority of what you're going through in life. Okay? Last one. Let's end it. Let's end it on a good note. Unraveling the pain trajectory in chronic low back pain patients during physical exercise. What does that mean? I'm going to jump to conclusion on this one. Pain decreases markedly during the initial weeks of an exercise program. Acute exercise-induced hypoalgesia. What does that mean? Well, hypoalgesia is actually a reduction in pain. So exercise naturally reduces pain. It's like, think of it like a physical form of aspirin, all right? And it persisted throughout the program, suggesting patients may use Physical exercise to manage pain flare-ups even after several weeks of training. Now, while they did get the biggest bang for the buck right at the beginning, there's a lot that could be done. There could have been the limitation on the study, how long it was. It could have been the types of exercises. It could have been, yeah, you take that initial dip in pain, but now you're going to push for more exercise and go harder. So now you're competing their pain flare up with some DOMS, delayed onset muscle soreness. So their total visual analog scale pain that they were using may be a little bit off. But at the end of the day, you have a natural acute exercise-inducing hypoalgesia. So for those people that are the chronic pill poppers, like I have to take my 2 to 4 Advil a day, we can seriously consider this as part of your pain management program. And it's not just because exercise is so healthy for so many aspects and factors of your overall health. Maybe in the short term, the immediate, this may be what we need to latch on to. It's like, fine, ignore the fact that you'd be more capable, ignore the fact, all of the other benefits. It may be a way that we can take care of this flare up and you don't have to see a provider as often to help you through. You don't need to pay out for a script. You don't need to pay out for a bunch of massages. You don't need to pay out for a lot of what I do. Maybe I still have to see patients, Anyway, bad taste, bad joke. Maybe we just ask that you challenge yourself to do as much tolerable exercise during a flare-up as possible, and we can use this natural physiological mechanism to our advantage to reduce your overall pain, to then allow you to tackle whatever needs to be tackled next to get you through whatever it is you're going through. All right. So in summary, lifestyle factors with low back pain, it's basically what we already know. Be due diligent on your screen time because it does play a role in your overall health. You have to find somebody to screen the whole body because of natural referral patterns, and don't just have somebody go, oh, it hurts there, therefore it is that. All right. Make sure that we consider physical activity as part of a pain management program. And if you or somebody potentially has symptoms indicative of a radiculopathy, and it's kind of one of those things where, yeah, I'm not sure, maybe I have this double crush. It's very, very hard from a layperson, and it's very, very hard from a clinician standpoint. More than anything else, this is just an awareness. I'm not saying anybody does or doesn't. Just bring it up to whomever is seeing you if you have this, or make it a conversation piece if you're helping somebody through something like this, so that appropriate levels of intervention or care are taken in the proper order without jumping straight to what I call an end treatment. Okay. So surgery is, I'm not going to demonize or bash or bastardize surgery. It is one of those treatments where it has to be for the right person at the right time for the right reason. You've heard me say that a whole bunch of times before, but surgery is the end. It is the final boss, so to speak, in most of these conditions, because you can't revert. There is no reversing it. Okay. If you have it, you've had it, it's done. There is no walking back from it, and you are altered from it. All right. So if it is for you, we better make sure it's going to be the best thing for you, and it's the best thing for you at the right time. Maybe it's not, because there's secondary factors that we can start with that may make the rest of your treatment approach much more approachable and tolerable, and you can avoid unnecessary surgery, which includes an unnecessary bill and unnecessary additional post-surgical recovery time, and free up those surgeons' schedules to treat the people that legitimately need the surgery at the time that they see the surgeon. All right. Another thing to think about. I've rambled a lot. I probably said enough that some people are going to tag on Instagram and, whoa, stop sharing my screen here. I've said enough. I'm probably going to get in trouble. Somebody is going to snip some things because I'm a metaphor guy, and I'm going to bring things up and compare things. Like, oh, did you hear what he said about these strongmen? Did you hear what he said about this? And you're taking things out of context. But yeah, at the end of the day, I think this was a good series of studies, and I look forward to seeing what comes across my docket next week. So until then.